Now I'm really honored to introduce our panelists today. Dr. Caitlin Carter is a pediatric and adult nephrologist at the University of California, San Diego, and the clinical director of pediatric nephrology at Rady Children's Hospital in San Diego. She's interested in the impact of hereditary kidney disease on patients and their families across the lifespan. And when not working to prevent and delay kidney disease, she enjoys being outside, running and hiking. She's actually joining us from her vacation right now in Idaho. It's rare to have to be double certified in both pediatric and adult nephrology, and we are fortunate to know one in Dr. Carter. And in full disclosure, I should note that Dr. Carter is my son's trusted and wonderful pediatric nephrologist. She was the one who diagnosed my son with Alport syndrome, leading to the understanding of my own misdiagnosis going back more than 40 years. Sharon Lagas, co-founder of Alport Syndrome Foundation and patient, planned to be your moderator today. Unfortunately, she's under the weather and we wish her well. So I am stepping in to be your moderator today. Laura Silverman is a licensed mental health counselor in private practice in Rhode Island. Diagnosed with Alport syndrome at age 48, Laura received a living donor kidney from her brother in December 2018. She lives with her mini Bernie Doodle and co-therapist, Avi, and her cats, Paul Newman and Maybelline, which I love. We're honored and grateful to have Laura here with us as well. Thank you both so much for joining us. I think we're going to get right into this questions and start with Laura. You know, I was fascinated to find that you were not diagnosed until your late 40s. And I wondered if you could share with us a little bit about then your sort of diagnostic journey and understanding Alport syndrome for yourself.
Thank you, Lisa. Yes, I changed primary care doctors when I was in my late 40s, and she looked at my labs and said, wait, you have hematuria and your father is a transplant patient. What's up with that? And I said, nothing's up with that. You know, I've just always been told it's a little hematuria. It's not a big deal. And so she said, well, let's make sure it's not a big deal. So she sent me off to initially a urologist. I underwent a lot of testing. That was inconclusive. I went to then a nephrologist, had a biopsy, and came back with not an Alport's diagnosis, but a glomerular nephritis diagnosis. And at that point, he put me on a low dose blood pressure med. And for 11 years, I took my meds and, kind of watched my kidney function steadily decline. And at 59, I was at the point where I needed to register as a transplant patient. And in that last year, my function declined rapidly. So interestingly, I'd had hematuria most of my life. Doctors always noted it when they did labs and basically said it was no big deal. When I look back, even in childhood, I had symptoms. I had, a lot of fluid retention. I couldn't wear knee highs. I would get terrible fluid retention in my legs whenever I tried to wear knee highs, and they would dig into my legs because I was swelling. And anytime I did any kind of physical activity in warm weather, I would swell right up. And so there were these little signs all along. And I was very physically active through my 20s and 30s and into my early 40s, but could never reach gain the stamina and that other people that I did things with, hiking, biking, et cetera, even though I worked as hard as they did. So there are these little signs and signals that something wasn't quite right. And I'm so grateful to my doctor who, recognized that there might actually be something going on here. I think knowing that I could have probably still have my kidney function had it been diagnosed earlier and I had started a blood pressure med earlier makes me a little sad. But it, you can't really dwell on the past, can't change it. So, yeah.
And now you're a very proactive patient, which is fantastic, very empowered. And we appreciate that you're here to help other patients today. We really appreciate that. Thank you for sharing that story. I too was misdiagnosed with IgA nephropathy for most of my life. And it wasn't until my son was diagnosed through Dr. Carter that I ended up understanding my own diagnosis. So Dr. Carter, this really plays into that idea of, what Laura was mentioning is treatment early. So I think one of the big questions that came to us early, because we did ask folks in our Facebook support group to ask questions in advance, and we will also get to our questions and answers that filter in here through the Q&A. What's a typical monitoring frequency for a pediatric female? And does that differ at all based on their genetic type? Can you speak to that for us?
Yeah, absolutely. So, if we're talking about women with X-linked Alport syndrome, which is going to be the majority of women with Alport syndrome, I think at least annual monitoring, even in the pediatric population, is really important, because we're looking for things like early decline in kidney function and changes in the amount of protein in the urine and those kinds of things that can be an indicator that starting a blood pressure lowering medicine, typically an ACE inhibitor or an angiotensin receptor blocker, would be important. For people or for women with autosomal recessive disease, I think it's even more important, and probably more frequent monitoring is needed. For women who have a family history of early kidney failure, particularly in other women in the family, I think more frequent monitoring is necessary. And now that we're getting more and more information about the specific relationships between specific mutations and risk for progression, I think that we can use that to guide the frequency of monitoring over time.
And it's important to understand that for sure, because I think a lot of us as parents had that question of how often should our children be evaluated. Is there anything specific you look for in the labs? That was one of the questions from patients in females versus males. And also sort of this helping us understand how you see maybe the new information that's come up from the Early Protect trial, where there's new pediatric recommendations, or sort of updated pediatric recommendations.
Sure.
Not from the American Society of Nephrology, but from Alport experts who've been involved for a long time, who published some articles about this. How do you see that? Is there a difference between how you any lab values that you look at between male and female, and also just treating pediatric patients?
Yeah, so I think that in terms of differences between male and female, I really think of it more as differences between, sort of identifying who is at high risk for progressive kidney disease, and those children and adults end up in a different category than patients who are at lower risk for progressive kidney disease. So we know, for example, that males with X-linked Alports are at higher risk for progressive kidney disease in general than females. We know that specific gene mutations are at higher risk for progression than females, or than other mutations. And so I sort of base it on a combination, the frequency of monitoring on a combination of factors that help me to assess their risk for progression. So that's genetic type, that's family history, that's how much protein do they have in their urine, what is their blood pressure, and then what is their estimated kidney function, or GFR, at the time of diagnosis, and sort of put all of that together in a constellation of, how likely do I think this individual is, male or female, to have progressive kidney disease over the next, 6 months, 1 year, 5 years, 10 years, and use that to put together a monitoring strategy. The things I'm looking for are the same, and they're all those things that I just mentioned. So kidney function, urine tests, blood pressure, those types of things.
That makes sense. We did get a question in the chat or in the Q&A, thank you, from a patient, Anna. She says, thanks for hosting this session. And can you comment about any research that's been done on infertility and or pregnancy complications, a miscarriage, preterm labor for women with COL4A4 autosomal dominant Alport syndrome? And I think one of the things to note is, from our medical advisory committee have mentioned that pregnancy complications in Alport syndrome are understudied. There really has not been any published study that we're aware of in specifically in Alport syndrome. It has been looked at in chronic kidney disease, and I know Dr. Carter can likely speak to that, but not in Alport specifically. And it's one of the reasons why we announced yesterday a new patient registry, sub-registry, with the National Kidney Foundation called the NKF Patient Network Alport Syndrome. We announced that yesterday in one of our sessions. You can click on your icon later that says patient registry and learn all about that. And one of the important reasons for building out this registry is to study the understudied complications of Alport syndrome, including pregnancy complications. But Dr. Carter, what would you say to, what do you do? Because I know you're double certified. When you do have patients that are planning pregnancy or are pregnant, what is your recommendation to them about, being followed and evaluated?
Yeah, so I think that most women with Alport syndrome or any type of kidney disease who are considering becoming pregnant should be followed in a high-risk OB clinic if that's available to you. We know, as Lisa said, we don't have specific data related to patients with Alport syndrome, but I think we can assume from the studies that have been done on pregnancy and chronic kidney disease and our understanding of perhaps an underdiagnosis of Alport syndrome, that there were probably Alport syndrome patients in those larger studies of chronic kidney disease and pregnancy. And I think that's an important point. We know that decreased kidney function and protein in the urine are risk factors for things like high blood pressure during pregnancy, for preeclampsia, so for sort of maternal complications, but also for fetal complications, so low birth weight, prematurity, those kinds of things. And the more severe your kidney disease is, the more likely you are to have both maternal and fetal complications during pregnancy. So I think it is really important that even if your kidney disease is relatively mild, if you're considering becoming pregnant, that you are under the care of someone who is, aware of the risks of kidney disease in pregnancy, and also can sort of advise you on guiding you through pregnancy. I think it's important because one of the features of preeclampsia is high blood pressure and proteinuria. I think it's important that those things, sort of the baseline, is well understood early in pregnancy, because those things normally change during pregnancy. So in normal pregnancy, blood pressure will drop, proteinuria will go up. So understanding where you're starting so that we can identify changes throughout the pregnancy, I think, are really important. And then just coming up with a strategy with a high-risk obstetrician for monitoring, for more frequent monitoring than is even typical in a normal pregnancy, I think is important.
That makes sense. Thank you. Yes, I was misdiagnosed, as I mentioned, with IgA nephropathy. And so I was actually seen and monitored by a high risk, seen as a high risk pregnancy. And so I was paired with an OBGYN who had experience with that. And that turned out to be very helpful. So that does make sense. And I know that members of our medical advisory committee who we've spoken to this about before have often said that they do recommend that when Alport patients are pregnant, that they get followed. Make sure that they get followed by an OBGYN with this kind of experience. We have some questions in the Q&A about genetics. And Laura, I'm going to turn to you and ask, do you happen to know, and are you okay sharing with us, do you happen to know your genetic type of Alport syndrome?
So I believe it's COL4A4, and I have ADAS.
ADAS. Okay. All right. That's helpful to know. And did you find that out through genetic testing, or?
I did. I actually didn't have the genetic testing until after my transplant. And I requested it because I have a lot of cousins who are symptomatic, whose doctors say things to them like, your cousin doesn't have Alport syndrome and stuff like that. And so I thought having, a genetic test would be helpful. And initially my nephrologist was reluctant to sign off on it because he felt like it wasn't necessary anymore. But I guess I made a strong enough case that he decided to go ahead and do it. And actually, when I first got my the results from Reata, it did not show Alport syndrome. It showed a mutation of unknown significance or something like that. And then just a few months ago, my doctor contacted me and said, we've gotten an updated diagnosis.
Oh, so that's interesting. You went through a genetic testing company, it was unknown, and then they got back to you once it became known.
Yeah.
The doctor, oh, that's fascinating. That's really interesting to know.
I think this is becoming more and more common, actually, as we start to understand, as more and more people are doing genetic testing. We look at someone who has a variant of unknown significance, but has a family history of end-stage kidney disease, and themselves has end-stage kidney disease. It makes us look back at the genetics and say, this isn't unknown significance. We do know the significance of this. This has to be related. And so I think a lot more of these variants are being reclassified. And I think that's the power of having more people do genetic testing, actually, is that the more data we get, the more we can understand the relationship between specific mutations and the risk for progressive kidney disease over time.
That's really important. And what you had mentioned, Laura, we're finding more and more. We're hearing that a lot from patients that'll email us or call us, get in touch, and say that they're having trouble. Their nephrologist is saying, "Oh, I don't think you need that genetic test. I'm not going to sign off." Or, "Why do you need to know? You have chronic kidney disease. Why do you need to know if you have Alport syndrome? Because there's no cure. There's no treatment." Which, that's really outdated thinking. Of course, there is current standard of care, and it takes away our power as patients to understand not only our potential disease progression, but get monitored for other potential complications such as hearing loss, eye abnormalities, who else is in our family may be at risk, and our opportunity to participate in research, or there are 3 human clinical trials right now. And so I really encourage you, if you're a patient out there and your doctor has said, you don't need to know, I really highly encourage you to become your own best self-advocate as a patient and let them know why this is important, that it is your right as a patient to know. And there are definitely genetic testing programs out there that are affordable, accessible these days. And if you're having trouble finding something, please, contact info@alportsyndrome.org. One person asks, what are the genetic mutations, Dr. Carter, that show increased risk for kidney disease progression? I know there are lots, but I mean, if you want to speak to that,
so there are a couple.
There
are a couple different things. So, if we think about the genetic code as being a sentence that sort of is translated into the protein that makes the collagen, that makes the kidney basement membrane, there are different typos that can occur in that sentence. So, the most common or the most severe mutations are mutations where the sentence or the paragraph gets cut off in the middle. So what we call a truncating mutation. So, in a male with X-linked Alport syndrome with a truncating mutation, the rate of kidney disease progression is going to be higher than in a male with, in general, these are broad generalizations, but in general, a truncating mutation will be more than a typo where 2 letters get switched around and maybe the meaning of the sentence isn't as affected as if it gets cut off in the middle. So I think that those are kind of the big generalizations. In terms of the differences with collagen 4A3 or 4A4 mutation versus a 4A5 mutation, so the autosomal mutations, we think that the same things apply, but it can be it's a little not as gender. And obviously, the rate of progression in females is the same as in males. So it has to do with what those typos are like and which gene it occurs in.
So when you're trying to help a patient understand, do you speak to that patient directly about it, or do you also encourage to see a genetic counselor? How does that work?
I do both. I'm fortunate because I work in a system where genetic testing is pretty readily available, and we have robust genetic counseling services. And part of that is, I think, being mainly part of a pediatric institution. I don't think it's uncommon for even adult nephrologists to resist genetic testing because it's sort of thought to be, as you said, sort of expensive and not maybe not necessarily beneficial. But I think that is changing. But I think it's hard. It's actually more difficult to get adult patients genetic counseling than it is to get pediatric patients and their families genetic counseling, just the way that our healthcare system is structured, unfortunately. Pregnancy is an opportunity for genetic counseling. So I think that it's important to take advantage of those if you're doing, preconception counseling or even monitoring during pregnancy. But I do encourage people to see genetic counseling if they think that would be helpful for them. It's something that I offer, but I don't push. If they feel like they understand it and have the resources that they need already, I don't push it.
Excellent. I will say that just for those of you who are considering it or want to know more, we recorded in your icons and for your event app, there's an icon that says genetics vid. And it's a video interview that we did very recently with a renal genetic counselor. Her whole focus is renal genetics. And it's information about genetics in general in Alport syndrome, understanding your own diagnosis, what to expect from a genetic counselor, what you can expect out of it, and how to prepare for that meeting to get the most out of it. And I will also note that a couple of the programs that we're aware of through Alport Syndrome Foundation that are trying their best to make genetic counseling more accessible, they actually offer several of them a free half hour with a genetic counselor if you do your genetic testing through them. And so, I would say I encourage you to make sure you follow up with that and use that time if you can, if you're interested, because you may learn something of importance. It's an opportunity. Dr. Silverman, there's a question here about, how do you about the idea of talking to your family members once you get your genetic test and it turns out you're positive and you have a genetic mutation that causes Alport syndrome, and you want to do your best to make sure you understand that some of your family members may be at risk. Can you speak to how best to inform and talk to your other family members? Some tips about that from your perspective as a mental health professional, to ask them to let them know and encourage them to get tested.
Yes, I can. So I think thinking of your role in sharing with family members, it's actually to provide them with information and suggest that they get evaluated. And so you're not pushing or insisting, you're just giving them information so that they can make their own decision and then kind of disengage from whatever that decision is. Because I think hearing that news and the possibility that they have a chronic condition can bring up all kinds of emotions that it may take them time to kind of sift through. And it may take them time to get to a place where they want to find out more about it. I can tell you from my own experience, when I spoke to my brother and my sister-in-law took her kids to the doctor immediately and had them evaluated and, spoke with their doctors and spoke, they were young adults at the time, but, explained to them exactly what was going on and was very proactive about it. My cousins, who is my uncle's children, he is now on dialysis. Many of them actually are symptomatic and they don't want to know. They're not interested. They don't want to go on a blood pressure medication. They don't want to know anything more about it. Their feeling is that they'll deal with it when the time comes. And that's their prerogative. And so they have all the information. They have copies of my biopsy. They have copies of my genetic testing. They have all the information that they need if they want to pursue it. But, kind of giving that information and then letting them make their own decision and not putting pressure on or not feeling like it's your job to make sure that they follow through and take care of themselves. That
makes sense. Yeah. I understand that's helpful. That hits home to me as well. That makes sense. I'm going to go to a question from Kristen, whom I adore, a patient, also from California. She says, at what point should a child start seeing a pediatric nephrologist instead of their pediatrician? This is a really good question. When blood presents or protein or before, Dr. Carter, how do you see that?
So I don't think that the nephrologist should ever take the place of the pediatrician or the internist. For just to be clear, I think we should be an add-on to the primary care doctor, for sure, because there are a lot of other things that need to be, outside of Alport syndrome that keep people healthy, that are really important for preserving kidney function, actually. So that's the first thing. So never in place of. But I think that, if you're a child with blood in your urine and you have a known family history of Alport syndrome, you should be seeing a nephrologist from the beginning, whenever that blood in the urine is picked up. And some pediatricians do routine monitoring for blood in the urine and some don't. But I think if there's a family history of Alport syndrome, your child should be being monitored for blood in the urine. If you have a male child with, and there's a family history of known X-linked Alport syndrome, my feeling is they should be seen from the beginning. I mean, maybe not birth, but at least probably 6 months, to just sort of come up with a strategy for what your monitoring is going to be like through childhood. And maybe, around 1 to 2 for other children with known Alport syndrome in the family, especially if there's blood in the urine. It's hard to get urine on little babies because they won't pee in a cup. And so, and it doesn't help us to do a catheterized urine specimen, for example, because it's going to have blood in it. So it's hard to make those identifying diagnoses early on. But I think that it's, but we can get some information from a bagged urine sample if we need to. So I think it depends a little bit, again, on the genetic history in the family, because early diagnosis is for X-linked Alport syndrome and for autosomal recessive Alport syndrome, because we do want to think about, at least have a conversation about starting ACE inhibitors very early. So in the first year or 2 of life in those children, I think it's important that conversation is had with a pediatric nephrologist who is informed about Alport syndrome and the benefits to early initiation of ACE inhibitors. For children with autosomal dominant or females with X-linked Alports, you can probably do that when they're 3 or 4 and able to pee in a cup and have a more informed decision.
That makes sense. One person raises something here that we hear once in a while, and it's something maybe we should address. This is females, but really everyone with genetic testing. Sometimes we're told by our doctors, this patient was told by a doctor, you don't want that on your insurance record. You don't want Alport syndrome connected to you for insurance reasons. I don't know, but does the genetic testing have to go? If it's on your record, Alport syndrome on your record, does somebody have to see that? Does insurance see that? Is that, Dr. Carter, do you know, is that necessarily the case?
So this is more of a policy and perhaps political conversation than a medical one, right? From a medical standpoint, there's a benefit to knowing and because of the benefits for early treatment. So there's that piece of it. In terms of, at this point, we're in I see Laura has her hand raised too, so I want to be sure to get her comment. But I think from a insurance standpoint, currently pre-existing conditions are not exclusionary for insurance providers. So they do have that information, but they're not allowed to discriminate against you for it. I will say for life insurance companies, this is one of the reasons that life insurance companies always did a urine test, was because they knew before we knew that blood and protein in the urine was a risk factor for progressive kidney disease, and they didn't want to associate with that. So I think, that's so from a medical insurance standpoint, the current laws in the United States, at least, are that you cannot be discriminated against for a pre-existing diagnosis, which includes Alport syndrome. What you want to do with that information otherwise, I think, is more of a question for Laura.
So I can tell you from my own personal experience that I have not been able to get any life insurance with a chronic kidney disease diagnosis. And that is the rationale so one of my cousins actually switched to my primary care, in part because he's symptomatic, and he wanted to have a doctor who would be more attuned to him, because his primary care at the time was just kind of, dismissing it. And so even my doctor kind of warned him that if he were to pursue genetic testing, it would affect his ability to get insurance, not health insurance, but life insurance, long-term care insurance, any of those insurances. And so I think that is a concern. I had one company offer me life insurance that was cost prohibitive and excluded anything related to kidney disease. So it was basically useless to me. So I guess I think it's a legitimate concern, and one that patients have to consider before they go forward if they, want to have life insurance or long-term care insurance.
Yeah, I will say
I was just going to say, I would be interested, I think that kidney disease in general, it can be exclusionary. So once you have for life insurance policies. And so, I don't know that that's specific to the genetic testing as opposed to being just because of the relationship between kidney disease and cardiovascular disease and those things over time. So I'm not sure that that the genetic testing necessarily puts you in this situation puts you in a different category, whether it's just the chronic kidney disease itself that impacts your ability to get life insurance also.
Yeah, that's helpful. I will say before we move on to other questions, I will say that in my interview with Mary Beth Roberts from Cleveland Clinic and this renal genetic specialist, if you do watch that video, she does mention that there is an organization called GINA, I can't remember exactly, it's GINA help.org, which gives you information that there is federal law in the United States that you cannot be discriminated against in work settings and insurance settings. There are some limitations to that, but based on a genetic disease diagnosis. So I will encourage everybody to check that out if it's a question that you have. We have another question. It says 49 years old with X-linked Alport syndrome, no proteinuria yet. At what point should I start taking an ACE inhibitor?
That's a great question. And I think that I think it's one that we will understand better, probably, hopefully by the time you're 59 than we do at this point. The current recommendations are to start ACE inhibitors early, which for women with X-linked Alport syndrome is at the onset of microalbumin in the urine. So not just protein in the urine, but sort of the earliest traces of protein in the urine. Because Alport syndrome is so variable, we're trying to not start people on ACE inhibitors who don't need them, but we want everybody who could benefit from one on one, and trying to distinguish those two populations can be challenging. Certainly if blood pressure is elevated, an ACE inhibitor would be the first, that's easy. The ACE inhibitor would be the first line therapy for getting blood pressure normal. But I think if you're 49 and you don't have albumin in the urine and your kidney function's normal and your blood pressure is normal, I think you can still wait. That may change, though. I think it's important to just remember that our understanding of the way that these medicines work to prevent kidney disease is changing.
That's really helpful. I think it's important because I think we have a lot of parents listening in, parents of children with Alport syndrome and girls with Alport syndrome. And one thing that I know that comes up a lot in my conversations with patients that email into us and contact us is something I experienced myself, I will say, is that feeling of guilt that we have unknowingly passed along a genetic disease to our children. I know I definitely, that struck me when I was first diagnosed. That was a little overwhelming. Laura, is that something that you can talk to us about, how you see that as a mental health professional? Because I know a lot of parents struggle with this.
So I actually did a little bit of research into that and learned that that's actually called genetic guilt, a term I had not heard before. And it can be excruciating and disabling. It can be really, really hard for parents. It's so important to get professional help if you're having that guilt and it's having a strong negative impact on you, because you can transform that from genetic guilt to an acceptance of your condition and your child's condition, and that can be transformative. A professional can help you learn to focus less on the guilt and more on how you can help your child thrive with Alport. And as a parent with Alport, you're in a really unique position to be able to do that. So, because there's nobody who knows better than you how to navigate it, right? Family support and social support increase the chance that someone will thrive with a chronic illness. And so you want to make sure that you're calling in your supports. You might not be able to eliminate the guilt entirely, but you certainly can learn to manage it. I recommend finding a therapist who's trained in acceptance and commitment therapy, which is also known as ACT. They are probably the best position to teach you the mindfulness and cognitive skills that you need to manage your guilt. And so ACT has a professional organization. You can look them up online and find therapists in your area. One of the advantages of COVID, or one of the good things to come out of it, is that teletherapy is more widely available. And so for people who don't have clinicians in their immediate area, they may be able to go out of their immediate area and still see somebody via telehealth.
I think that's great. We just hear it often. And in fact, I think sometimes just being able to connect with other families and patients who feel the same thing is helpful, knowing we're not alone in that.
Yes, getting support through the Alport Syndrome Foundation support group, which is an invaluable resource.
It is. I'm glad you mentioned that because I know you're active in that group, and it's how we found you, because you always really have excellent responses for us. So, that other also leads into this, our conversations with our children and talking to our children about their disease, girls. And I assume this is with boys as well, but, talking to our children about living with the chronic kidney disease. Do either one of you want to speak to that? Or, well, I guess I'll go to Laura first about, tips about talking to our children at various ages.
So you want to keep them in the conversation at an age appropriate level. And so you want to make sure that you're giving them as much information as they can process and handle. You definitely want to make them a part of the conversation with their doctor, so that if they're having any questions or concerns, they feel comfortable asking those questions. And working with the pediatrician and the nephrologist to figure out what is the age appropriate things that I can talk to my children about at this stage. I strongly encourage any family who's dealing with chronic illness, parents who have it themselves or have kids with it, establish a relationship with a therapist. Even if you're in a good place at the moment, having that relationship in place so that when things do come up that are stressful or when crises happen, you already have an established relationship with somebody who can help you navigate that is extraordinarily important. And for your child who's going to, have different issues as they get older and understand more about about Alport and the potential effects of it, having a person that they already know that they can go to and talk about those things safely is really beneficial.
I appreciate you, that perspective. I think that sort of bears out in, I'll point out to the attendees here that if you go into your app for this event and you click on Pediatric Insights, it's a report that we just published after a year and a half of work of talking to 25 different young Alport patients, pediatric, and sort of capturing their insights and lived experiences. And we have a report there. It was a series of Zoom gatherings and one-on-one Zoom meetings and surveys. And it came out of initially inspired by a conversation with our medical advisory committee member, Dr. Bradley Wardy. He's a noted pediatric nephrologist who does a lot of research. And he advised us on this project and on the surveys. And one of the things that he often talks about is that addressing the psychosocial aspects of living with chronic kidney disease, particularly Alport syndrome, is really valuable and critical, almost as much as taking their ACE and ARBs, because it's so important for understanding your disease, to also be compliant with medications, understand why, but also all the psychosocial things that happen with potential hearing loss, living with anxieties about your future. Perhaps you know someone in your family that has gone through kidney failure and you're concerned for yourself. So I would encourage you, all parents, to sort of look at that Pediatric Insights report, because it is really revealing, and it is expresses the lived experiences of young Alport patients. But it's not all negative. It's also very positive, because a lot of them have gotten engaged, empowered, confident, embracing who they are, connected to a community of patients that they can relate to. And they also have tips on their own advice and words of wisdom on what they would say to families. Dr. Carter, do you want to speak to that at all, about talking to young patients about their disease?
Yeah, I mean, it's one of the really challenging things, I think, in my experience managing children with chronic kidney disease, is sort of how do you, especially if we're talking about, I see a patient every 3 to 4 to 6 to 12 months, maybe they're not going to come to me with what their fears are, or, they're not going to be as open with me right off the bat. And so sort of that, I think there is an importance in establishing, that I'm someone they can ask questions to, but I think it's more likely that they're going to go to their parents with those questions. And I think it's very complicated for kids, especially kids whose parents are on dialysis, for instance, to go to their parent and say, I'm afraid I'm going to end up like you. Like that's a hard thing for a child to say to their parent for any reason, but especially if it's chronic disease. So I think, I try to create some space in the visit, but also I try to encourage kids, if there's something you're worried about, you can tell your mom, because maybe they're going to tell their mom when they're out for a walk or driving to soccer practice or going to bed that night or whatever it is, and sort of trying to have them know that they can communicate with me in between the visits so that we can talk about these things. So I think those are some of the strategies that I use. You can't talk to a 5-year-old about kidney failure. That doesn't mean anything to them. But by the time they're 10, if they have a family member who's been through that, they can understand kind of what that is. And so sort of those graded increases in explaining things. And here's what we can do to prevent and delay kidney disease and those kinds of things is, I think it's a really important part of the conversation, and really important starting when they're very young, so that they can feel empowered to ask questions and those kinds of things.
I appreciate that. And I will also do a shameless plug right now for our new coloring book, Annie Has Alport Syndrome. We were able to, with the support of our generous sponsors for this event, we were able to create this coloring book for families. And if you, at registration, you said that you have someone in your family under the age of 12 living with you, and you're an Alport family, we have sent that to you. Or if you registered after July 14th, it's going to be in the mail next week. But if you did not note that and you want a coloring book, please email info@alportsyndrome.org, because it's a story about a young girl with Alport syndrome, and it encourages families to talk about Alport syndrome at an age-appropriate level. I'm going to jump back into some other questions from the audience here. Jess asked, Dr. Carter, from your standpoint as a pediatric and adult nephrologist, have you witnessed atypicalities in female anatomy that would lead you to believe Alport patients may be more susceptible to PMDD and or endometriosis?
So, there's a known association between females with X-linked Alport syndrome and uterine fibroids and endometrial, which can lead to sort of higher rates of heavy menstrual bleeding and those types of things. And we think it's related to overlap between the collagen 4A5 and collagen 4A6 mutations. So there is that piece of it. It's not common, but there is a genetic explanation for why that might occur. In the absence of that, I'm not aware of any specific, abnormalities. But, we know that Alport syndrome, right, it's a collagen disorder. Collagen is found in lots of different places in the body, including lots of the vascular system and those kinds of things. So I think it makes sense that there may be an association. But again, I think this kind of goes along with what Lisa was saying earlier, that particularly the gynecologic and obstetric complications of Alport syndrome are just not well studied and understood. And so I think there's more we have to understand there.
Thank you. Actually, I definitely learned something there that I was not aware of. And also I'll add that then this leads into a similar instance of something that's understudied is Pauline comments that COL4A5 ascending aortic aneurysm at 63, that she was in total surprise to discover that she needed immediate open heart surgery for an aortic aneurysm. This is something that is not seemingly not well documented. We are aware of at least one published study by an Alport researcher some years back, which followed, I think, 4 or 5 young boys. But at the time, that article suggested some years ago that it was only found in X-linked males. Now, just by talking to patients, we've found some reported instances of X-linked Alport females telling us, like Pauline, that they've experienced aortic aneurysm. Is that something that you're aware of, or is this something that's happening in nephrology at all that's being talked about?
I think it's an evolving story. I think we're understanding. Like I said, I think we're just understanding more and more about the other vascular complications of Alport syndrome. High blood pressure is a risk factor for aortic dilation as well. So it's a little bit hard to tease out what's high blood pressure, which you're also at risk for with Alport syndrome, versus what's an underlying genetic cause of abnormal aortic dilatation. So I think that I would say come back to that in 5 years. Maybe we'll know more.
And I would also
we're going to know more, I think, is the point.
Yes, and part of knowing more is capturing this data. So again, I'm going to do a shameless plug for please, when we get our NKF patient network Alport syndrome sub-registry up and going, the date is November 15th when we believe it will go live. If you want to know more about that, you can click on patient registry in your event app icon there, and you can sign up your email just to get information about when it goes live and the status of that project. So if you want to participate, patient data is just so valuable, and we want to capture this kind of information so that it can be studied. Let's go to other questions. Amber asks, is there a network of nephrologist Alport experts that come highly recommended from ASF, like Dr. Carter? Finding the right nephrologist is really, really tough. I mean, we do keep a list of nephrologists in different cities across the United States. That patients know that our medical advisory committee members have told us are Alport knowledgeable. But it is rough finding the right nephrologist. Dr. Carter, what would you say if somebody finds that their nephrologist isn't really Alport knowledgeable? Any suggestions on how you handle that or find somebody?
So I think you shouldn't be afraid to switch doctors if you don't feel like your doctor is meeting your needs for whatever reason. So whether that's medical issues, or whether that's how they talk to you, or you can't get in to see them, or whatever it is, I don't think you should be afraid to switch doctors. And if I had someone in another town who needed an Alport's nephrologist, I would probably ask the Alport Syndrome Foundation for reference from your list, or ask one of my colleagues that I know. But I think that you shouldn't be afraid to. I guess you shouldn't be afraid to switch doctors. There's I think that there's a lot of people out there who are really engaged in treating Alport syndrome. And so I think everybody who has Alport syndrome deserves to be taken care of by someone who cares about their disease. So
that's helpful to have that. To me, that's empowering to have a doctor say that, to say, yes, you deserve a knowledgeable medical team, and don't be afraid to switch. That's powerful. Appreciate that. There's a question for Laura here. Can you go into more detail on what energy loss you were experiencing? This patient says they have a diagnosed family member who's experienced extreme energy loss. Did your energy levels get better after your kidney transplant, or was anything that was done to treat this?
So as my kidneys failed, as my function declined, I found that my energy decreased dramatically. And so in the last year before my transplant, I was exhausted all the time. I had enough energy basically to go to work and come home and not do much else. I think I had mentioned to you, Lisa, at one point, I have my Sundays, and I have kept that kind of sacred. My Sundays are normally what I call my couch day, where I just, plan to spend the day at home, not doing anything if I don't want to. Often I have more energy than I think I'm going to have, and I end up doing something, but I reserve the day so that I don't have to if I don't want to. But I worked really hard at staying fit through all of that. So I think that my energy level was maybe a little bit higher because I was still exercising regularly. And I was eating really well and doing everything that I could do to preserve the little bit of energy that I had. So I was really strong going into my transplant and really fit, ironically, even though I was at end-stage renal disease and needed a transplant. And in the days following the transplant in the hospital, I was walking 3 miles around the floor because I could, right? Which was kind of amazing. But I think following those recommendations for care, to make sure that you're eating well, to make sure that you're getting adequate rest, to make sure that you're exercising regularly as you can based on where you are in terms of your health, and getting the rest that you need. So planning those couch days or time off if you need it, so that you're not pushing yourself beyond what you can do and then getting to a real stage of exhaustion is really, really helpful. Post-transplant, I had a lot of complications. I was in and out of the hospital. I had a lot of problems with medication becoming toxic to my kidney or toxic in other ways, or actual anaphylactic reactions to medications. It took about 1.5 years to actually get my meds right. And so my energy really waxed and waned during that time, depending on what else was going on with my body. And to be honest, then COVID hit before everything was, and like everyone else, I got depressed. And so that impacted my energy. But I can tell you that today my energy is so much better. And I don't use my Sundays as a couch day nearly as often as I used to, because I don't need to, which is really exciting. And I'm returning to a level of fitness that feels comfortable for me. So yes, definitely an improvement.
That's good. We like to hear that, and I think that's so many people's stories too, is sort of the wave of the up and down. Dr. Carter, we have a patient that is asking about, I think this is actually an interesting question, one that I have too. How does menopause affect Alport, if at all?
So, in terms of specifically the hormonal changes with Alports, we do see changes in blood pressure and cholesterol and those types of things, which are important predictors of progressive kidney disease that occur with the hormonal changes in menopause. I don't know of any, specific interaction for women with X-linked Alport syndrome. Menopause often sort of overlaps with the time of declining kidney function. And so I think that the fatigue and some of the symptoms that we see with menopause can be indistinguishable or perhaps amplified because we have concomitant decline in kidney function. I think I'm pretty adamant about not starting systemic hormonal therapy in patients who have high levels of protein in the urine. So that can sometimes limit the symptomatic treatment options in terms of, that therapy with estrogen and those types of things. But those are kind of the big things that come to mind. If there's a specific concern that I would say, I'm taking care of mostly children right now, right? So I'm dealing mostly with menarche, not with menopause. But if there are specific menopause related questions, I'd be happy to answer those. That's kind of what comes to mind.
Yeah, that does make sense. So we often get questions about diet, and one patient is asking about, would you explain about a special diet for Alport and how important it is? I think this is something we get across the span, because I think it might be different for children and their needs versus adults. So Dr. Carter, can you speak to that, what you talk to your patients about in terms of renal diet?
Yeah, sure. So, as you said, the diet changes across age groups, but it also changes across levels of kidney function. So a lot of it depends on, will depend specifically on what the child or adult's level of kidney function is. I will say that I think diet and exercise are really, really important. And I think Laura speaking to this is really powerful, because I think everything we can do to decrease the risk of, or the rate of, kidney disease progression in people with Alport syndrome is beneficial. And we know that things like high blood pressure and high cholesterol and obesity and overlapping diabetes and those kinds of things can accelerate the decline in kidney function. And so sticking to a healthy diet is important for all of those reasons, but it also is probably going to protect the kidneys a bit. I think that as Americans, we could do a lot better in terms of limiting processed foods and eating more fresh fruits and vegetables, lean meats, whole grains, all of the sort of standard normal healthy diet things. I see that the question specifically mentions protein supplementation, and I think this is a really, really common question, particularly for athletic teenage boys. And what I try to explain to them is that the kidney has to work to get rid of that extra protein. So I don't restrict dietary protein intake, but I think most boys, most children and young adults can get all of the protein they need from lean meats, dairy, some eggs, those types of things, and that the excess protein that comes in supplements and shakes and those things actually can be more harmful for their kidneys than beneficial. But it is really, I find that's one of the harder dietary conversations, is sort of the athletic teenage boys, and protein has become so sort of popular in the sports culture right now. But I do think there are some potential harms that can come from that in this group.
So do you recommend at some point a plant-based protein diet, or is that something you talk to patients about?
I do. I think it's hard. I try to, I think the goal is for kids to eat a diet that is sort of culturally appropriate for them. So in different families, that looks differently. For families who are able or interested in doing a plant-based diet, I try to help guide them. And I think there may be some benefits to that. But I think that trying to say, okay, this is what your culture eats, and these are the things, eat more of this and less of this, is sometimes more sustainable for families. Because saying to the boy with Alport syndrome and his mom, you need to eat like this, and then dad and the other kid get to eat whatever they want, doesn't really work for families. And I think it's important to sort of incorporate the goal here is for everybody to have sort of as normal and healthy a life as they can. And we're really talking about things across the lifespan, right? So if you start to really get restrictive when a kid is 10 or 12, they're going to revolt when they're 17, and then you've lost your window for benefit. So I try to kind of keep it all in perspective.
That makes sense. Someone has asked us to go back for a moment to the menopause conversation and explain why hormone therapy is not advised.
That's a good question. So in all patients with high levels of protein in their urine, there is and there is an increased risk of blood clots and estrogen, external systemic estrogen therapy. So we're not talking about the vaginal estrogen and local estrogen therapy, but oral estrogen therapy can increase that risk of blood clots, and that can lead to things like stroke and those types of complications. That's also true for patients with high blood pressure. So there's sort of a narrow window of Alport's patients who maybe it would be safe for, but I think that that's an important conversation to have with whoever's prescribing the hormonal replacement therapy for you.
That makes sense. I'm going to go back a little bit to something we talked about before with the mental health aspect of living with chronic kidney disease and Alport syndrome. I think it's on a lot of our minds before we end our conversation at some point today, to make sure that we acknowledge the environment that we're living in with COVID. And, we're hearing from a lot of patients, especially the ones like Laura, who are post-transplant, who are living immunosuppressant lives, but also we're also aware of our own chronic kidney disease as an underlying health condition for COVID. And there are a lot of anxieties about that out there. Laura, is there something that you can speak to for us as chronic kidney disease patients, Alport patients living in the world in this COVID environment, in terms of addressing that sort of daily anxiety about going outside our homes?
Yeah, so that's a great question, and it's a huge challenge right now. And I think the best thing to remember when you're in a crisis, and we're in a national crisis, all of us, and I think those of us who have Alport or other chronic illnesses are in even a little bit more crisis than people who don't, is to try and identify what's in your control and what's not in your control, and to focus on the things that are in your control. So our natural tendency is to really focus on the stuff that's not in our control. And all that serves to do is increase our anxiety. And so if you are able to kind of take a step back and figure out what's in your control and what are the steps that I need to take to gain the control that I have. So some of the things that are out of our control include governmental policy, to some of the decisions that our family, friends, neighbors, and local merchants are making about how they're going to set policy to respond to COVID. And that kind of makes it feel like we don't have any control. But you're left really with the control over your own decisions and choices based on the information that's in front of you. So some things that are helpful are to stay informed, but only to the degree that you can tolerate, because too much information can be anxiety, can cause more anxiety. So if you're watching or reading the news is causing you an undue amount of stress, then take a step back. And from consuming media, you can take a news fast if you want to or need to, or you can limit it to, following one or two news outlets that you trust and get your information from those news outlets, and then turn the rest of it off. One of the things that I'm seeing is a lot of universities and are hosting informational Zoom meetings. Like Brown University has a Zoom meeting coming up on Tuesday to talk about the Delta variant. And that's a great place to get up-to-date relevant information. And they're making those meetings available to the general public. So if you see, meetings like that, that's a really good place to go to get good information. And then I think the next important thing is to identify your tolerance for risk. It's going to be different from people who aren't medically vulnerable, and may even be different amongst people who are similarly vulnerable. And there's no right or wrong degree of tolerance. Mine is actually pretty low. And so I'm almost quarantining still, because I know I have a low tolerance for risk. And if I make different choices, it causes me a lot of anxiety that I don't want to deal with. Once you've identified your risk tolerance, you can figure out what you feel safe doing and what doesn't feel safe, and make your own COVID rules and stick to them. Don't allow people to convince you to do things you're not comfortable doing. Don't let other people's feelings about your rules change your mind about what you're comfortable doing. They may have a higher risk tolerance than you do. They might have a different situation than you do. And ultimately, it's not worth the anxiety you're going to experience. So like I said, I'm not completely quarantined, but my activities are severely limited. I'm still doing the majority of my shopping online. When I do go to the supermarket, I go at 8 o'clock in the morning when nobody else is there on Monday, because that's the day that nobody's there. There's sometimes I call at the morning of a medical appointment and say, you know what, I'm not feeling comfortable today. I'm going to do a telehealth appointment instead of coming in. And so being comfortable, advocating for yourself, asking for what you need, and not making decisions, not thinking that you have to do things that you don't feel comfortable doing. I also suggest that you advocate for yourself in situations where you might be able to influence policy. So I couldn't change Whole Foods and Trader Joe's mind about discontinuing their senior days, right? But I did get a local restaurant to reinstate their contactless pickup. Because they weren't really aware of the risks to vulnerable populations. And when I explained it to them, they said, that makes sense. And we actually serve a lot of seniors here. And so we're gonna bring stuff out to people's cars. So you might actually be able to, make some change. Or maybe you decide not to shop at that place or eat at that restaurant, get your takeout from that restaurant anymore. And finally, find ways to expand your world. Take up a new hobby or interest, revisit old ones. Challenge yourself to learn something new, utilize technology to connect with friends and family or participate in professional development. The more engaged and fulfilled you are, the less you will focus on your anxiety and all of the restrictions that are imposed on you by COVID. So I think those are probably, I think that probably covers it.
I think that's a really good list. I'm going to go back and watch this recording and take the notes on that, because that can definitely apply to my own situation. We have a few minutes left. And before we sort of get into the ending part of this, I do want to make sure that we have one more really female-centric question. Someone asked this, are contraceptives for Alport females an area of concern? Dr. Carter?
Yeah, so I think that's another really good question, and I think it sort of tails with the estrogen question for estrogen replacement therapy question for menopause. So I think because of the potential fetal defects related to ACE inhibitors and angiotensin receptor blockers, it's really important that young women who are at of reproductive age, that they have good birth control, because I think it's a really, really important thing. So again, it's a conversation that I have with each patient based on what their risk of becoming pregnant is, which I assume in all teenagers is high. Because that's what it is. And then, so, assuming that they're at risk for becoming pregnant, how much protein, again, it's how much protein do they have in their urine? What's their blood pressure? So what's the trajectory of their kidney function? And how do we weigh the risks and benefits in each of these circumstances? I think as kidney disease gets more advanced and therefore cardiovascular diseases risk is increasing, as blood pressure gets higher and as protein in the urine gets higher, I move away from the sort of full dose estrogen oral contraceptives and try to come up with alternatives, whether that's, an IUD for those who are interested and willing to try that, whether that's progesterone only birth control, either, or Nexplanon or some of the other implantable contraceptive options, or I think a little bit safer. So those tend to be what I encourage in my young women with Alport syndrome.
Excellent. Thank you. Quickly, also, I want to also say before we lose time here, that again, if your question just did not get answered live, or there was no typed response to you from ASF, please know we are downloading all these questions. If it didn't get answered, we will follow up with you and answer your question. Unless you asked it anonymously, then we don't know how to get back to you. So if we respect and appreciate that, but if you are asking your question anonymously and it didn't get answered, please email us at info@alportsyndrome.org so we can get you that answer. And of course, if we don't have it from ASF staff, we would go to our medical advisory committee and get those questions answered, or to one of our panelists today. I do want to ask this question. There's another female-centric, Dr. Carter, for post-transplant Alport women, are there any new immunosuppressants on the horizon that are optimistic, since many long-term ones cause, problems and side effects?
Yeah, I mean, I think, right, the holy grail of all of transplant immunology is to find medicines that work and have no side effects. I think we are moving. I think there are some things that are emerging, so that our traditional sort of calcineurin inhibitor, mycophenolate, and steroid regimens. I think there are some things that are emerging as potential options for people who don't tolerate those regimens. But I think it's been slow, and I think it's been really, those have been reserved as second and third line therapies as opposed to as first line. I am hopeful that for all of our kidney transplant patients, whether it's Alport syndrome or some other form of end-stage kidney disease, that we will have better options for immunosuppression from the get-go, in the future. But I think that's still sort of emerging and mainly used as second line therapy right now.
Excellent, thank you. I do also want to take a moment to remind everyone that as a patient, you hold so much power in helping push research forward in so many ways. Researchers can't find these things. Pharmaceutical companies can't really get stuff in the pipeline unless they really understand what our unmet needs are. So that's a plug to definitely get involved and register in Alport Registry. Please click on your diagnosis stories in your app or on our website at alportsyndrome.org. If you haven't provided your Alport story of diagnosis through these surveys, we're capturing those and reporting them out to the medical community. That's really helpful for them to help understand our stories. Also, there's a researcher, Dr. Laura Perrin, who was one of the first folks to receive a direct award from Alport Syndrome Foundation in research, and she's doing research in females who give birth, who are Alport patients. If you're interested in participating in that research, which is uninvasive, please contact info@alportsyndrome.org and we can get you connected if you have any interest. So, it's so powerful to have your diagnosis stories, to get involved in a registry, to participate in a registry, so that we can help the researchers and the clinicians treat us, research us, and work toward better treatments, improved treatments. Hopefully at some point, something approved for Alport syndrome, and maybe more than one thing to treat us at different stages of disease, and maybe a cure one day. But the power lies with us as patients to participate in these things. I want to thank you so much, Dr. Carter. And Laura, that's so lovely to have both a patient and a mental health professional. Thank you, attendees, for your great questions. And again, if we didn't get your question answered here live, we will definitely answer them directly. Any parting words from you, Laura?
Thank you so much for having me, and Dr. Carter, thank you.
We look forward to your continued great feedback in the Facebook support group with patients. And Dr. Carter, any last words from you?
No, just thank you for having me, and it's been fun to answer all these really good questions.
Thank you so much, both. We appreciate your time so much.